I have been here for more than 15 years, dedicated to veterinary cardiology. I realized a very important problem. There is very little information with respect to congenital heart diseases. Therefore, this will not be a simple video. This is going to be a video with very high value content in which I am going to describe a case of one of the congenital heart diseases most frequent in dogs, aortic stenosis. And get ready because I will give you a surprise that is undoubtedly going to be a bomb. I am Dr. Jorge Banda, and if you are a veterinary medicine student and a cardiology enthusiast like me, you will love this video. Like the video and share so that more people have this information that can help them with their patients and attentive, because every 1 or 2 weeks I will be uploading videos with very important information for veterinarians and pet owners. Case presentation. I will begin by presenting the case. Out of respect, we will not show the patient's face, nor to mention his name. It is a mixed breed canine. Whole male, 1-year-old and weighing just over 5 kilos. The patient does not have vaccines, and in fact, does not make it to the clinic for a cardiac study. But the patient, suddenly, presented with a severe respiratory process and frequent seizures. You can imagine what the patient arrived with. However, during the physical study, during the patient's physical evaluation, I found a characteristic murmur. And this is how we suggest to its owner to carry out a complete cardiac study. This channel is a veterinary cardiology channel, so what I will do next is to describe the examination and findings I had with this patient. Everything is always oriented to heart function. Auscultation. On auscultation, we found a systolic murmur with a point of maximum intensity to the heart base, almost under the armpit, in the left hemithorax, in the fourth intercostal space, which corresponds to the aortic focus. And systemic pressure. I found it in the physiological range for the canine species. Electrocardiogram. On the electrocardiogram, the main finding is a third-degree atrioventricular block, third degree, with escape rhythm in the junction zone. As we see in the images, there is a dissociation between the P waves and the QRS complex. As we know, the P waves refer to atrial depolarization and contraction, and QRS complexes do the same with the ventricles. Therefore, a third-degree atrioventricular block, or complete in simple words, means that the atriums and ventricles are contracting independently, to each his own. This is known as complete ventricular atrium dissociation. And logically, that is something that cannot happen for the heart to fulfill its pump function. At this point, I would like to make an observation. No bibliography to describe a relationship between this bradyarrhythmia and congenital heart pathology. We are describing subaortic stenosis. However, as we know, the compact atrioventricular node is located on the ground of the right atrium. On the floor was right earpiece at the level of the atrioventricular fibrous skeleton. And as we will see later, the lesions that patients develop with this congenital pathology are quite close to the septa, interventricular interatrial, and the atrioventricular junction area. It is therefore it's probably that these injuries are responsible for the blockage. However, I leave open the comment box to see if any colleague has any references or any experience in this regard. Echocardiogram. Before going to the ultrasound images, I will describe the pathology using images in 3D. From the book Cardiology 3D in Small Animals. I highly recommend this book because through technology allows us to use images in 3 dimensions, through which we can observe each of the changes and injuries of the different acquired and congenital pathologies of our patients. We can see external changes in a heart, and also allows us to see injuries in the cameras internally, in such a way that it seems we are traveling through the heart chambers, is a very useful tool for learning. Aortic stenosis is defined as the increase in speed of flow through the aorta, associated with lesions that may occur in the valve area, or supravalvular or aortic subvalvular areas, and determine a partial obstruction of the left ventricular outflow tract. In the canine species, supravalvular aortic stenosis is extremely rare. Valvular aortic stenosis is infrequent and constitutes about 10% of the cases, and subvalvular aortic stenosis, by far the one with the highest density, and constitutes around 90% of the cases. In fact, this patient whom we are evaluating meets this statistic, as it presents this subvalvular injury. So from now on, we will call your pathology with the corresponding name, subvalvular aortic stenosis. There is still a controversial point with respect to this pathology, and is whether or not the pathology is congenital, because there is bibliography describing Newfoundland puppies to which no injuries were found at birth, but were developed during its growth. In people, the progressive nature of subaortic stenosis is well recognized, and apparently the same thing happens in dogs, since, as we have already said, of puppies that are born without the lesions and develop them during their growth. That is why in this particular pathology, it is very important to make the diagnosis as early as possible, but also carry out a control at 1 year of age, because there is a chance that the patient will worsen its injuries and finally develop a more severe pathology with a worse prognosis. External change, more relevant, if we could see the heart externally, is the poststenotic dilatation. As we know, the left ventricle, consequence of pressure overload by obstruction of the left ventricular outflow undergoes internal remodeling, concentric hypertrophy, and this is not evident externally. Therefore, the leading change is poststenotic dilation. Poststenotic dilation, which also can be seen on radiographic projections thoracic. In this three-dimensional heart, we can see an increase in size, the volume of the aorta artery, of the regions corresponding to the ascending aorta, and part of the aortic arch. Subaortic stenosis can present different morphologies that have been defined according to necropsy and catheterization studies Pyle and Patterson made in classification and defined 3 types, type 1, type 2, and type 3. The patient we are analyzing presented type 2, and the image of the heart in 3 dimensions also describes this injury. Type 2 subaortic stenosis constitutes a lesion of the subvalvular area of the endomyocardium, forming a complete or incomplete ring, originating at the base of the anterior valve of the mitral valve, and extends into the septum, as we can see in the images. Circular ring-like injury can be seen, which is just below the aortic valve, and partially obstructs the left ventricular outflow tract. Well, we enter the meat of the video. The echocardiography. The echocardiogram probably is the complementary test which provides us with more information on this pathology, allows us to highlight injuries to the heart, i.e. to make the diagnosis, also allows us to analyze the remodeling changes that occur in the heart, consequence of pathology, also allows us to analyze the severity of the pathology, i.e. to make a classification of the pathology through the Doppler study, and finally, measuring cardiac systolic and diastolic function, because these tell us if there is insufficiency. In an echocardiographic study, the first analysis is subjective. In a right parasternal cut, 4-chamber long shaft, we must value the appearance of cardiac structures, movement and size of walls, heart cavities, pericardium, septa, valves, etc. In a healthy heart, the ratio between the ventricles is 3:1. In this patient, there is an increase of the left ventricle. For me, the proportion between the ventricles for this patient is 4 or 5/1, and it is also evident a curve of the interventricular septum to the right, i.e., a displacement of the interventricular septum to the right, and this is an indicator of volume overload. But sorry, this is a patient with subaortic stenosis, and this pathology causes concentric hypertrophy, severe left ventricular, by pressure overload, which it submits to this camera. In this heart, we are appreciating volume overload indicators. Then what happened? The question is valid, but this patient has a particularity, and it is that in addition to subaortic stenosis, has aortic insufficiency, i.e., in addition to having a partial obstruction of the left ventricular outflow tract, its aortic valve is insufficient. Aortic insufficiency implies reflux from the aorta artery into the left ventricle in diastolic phase, and this results in an overload volume of left ventricular. This overload volume is the one that completely alters the heart remodeling in such a way that we no longer have the typical concentric hypertrophy that we would have in a patient who only suffers from subaortic stenosis. So we have the left ventricular with increase in thicknesses of septum and the free wall of the left ventricle, and also an increase of the camera by to volume overload. Now, we will describe the protagonist of this video, the aorta artery. But first I will describe a parameter, of which little is said in veterinary texts, the aortoseptal angle. This is an anatomic and functional parameter. It is the angle formed between the longitudinal axis of the ascending aorta and the interventricular septum, and it is an important angle because it influences flow efficiency through the aorta. We have already mentioned the dynamic nature of this pathology, and this angle is considered a factor that influences this progression of the disease. The vascular endothelium is exposed to hemodynamic stress generated by blood flow through the blood vessel, which we call shear stress. This shear stress is defined as the force exerting the blood flux on the vascular wall, and it is known that when the aortoseptal angle is altered, there increases this shear stress and stimulates the proliferation of the vascular endothelium and fibrous tissue, so it's aggravating the lesions that obstruct the left ventricular outflow tract. Studies indicate that patients with an aortoseptal angle less than 140 degrees develop more serious injuries and therefore have a worse prognosis. For this patient, the aortoseptal angle was 117 degrees. In the different cuts, right parasternal, left parasternal and subcostal, we must do a deep analysis of cardiac structures involved in pathology. We must evaluate the interventricular septum, mitral valve base, the aorta artery and its valve. And so we can make a lesional description. As we can see in the images, the injury we had previously described can be seen with the help of the cardiology 3D in the aortic subvalvular area. A structure is visible, circular and hyperechoic, originating at the base of the septal valve of the mitral valve and extends towards the septum. Therefore, with this information, we can now conclude that this patient suffers from type 2 subaortic stenosis. But I would also like to describe a particular injury of this patient that you may already have noticed in the previously shared images. I did not find this injury in veterinary texts either, and from here I thank you and send a big hug to my teacher, Dr. Javier Rodriguez. That helped me with this anomaly that she was new for me and led to confusion. This injury is this one from here, and it is an aneurysm of the interventricular septum. This injury consists of an interventricular defect, non-permeable, i.e., there is no shunt between the cameras, but a membrane is observed, a tissue protruding into the right ventricle. At this point, I will tell you about an experience so that you can be forewarned. When I was evaluating this patient and scanning with the colored Doppler drawer in all cardiac structures, and I was located at the base of the aorta artery, at times I had the feeling that the aliasing Doppler color was continued from the left ventricle to the right ventricle. Therefore, at times had the impression that the patient also had interventricular communication. In this right parasternal cut, 5 camera long axis, we can see how the Doppler color drawer program records aliasing, and at times gives the feeling that the aliasing is introduced. Continues to the right ventricle. But what actually happens is that the turbulent flow is introduced into the aneurysm injury of the interventricular septum in that little bag that was generated and that we had already reviewed in such a way that the colored Doppler box records the turbulence, draws aliasing, and at times we have that feeling that there is a communication between ventricles, and logically we may make an error. This is how I evaluate in depth, in detail, to the interventricular septum, the base of the aorta artery, and I find the interventricular septal aneurysm. But, of course, the correct thing to do, when in doubt, is to always perform the positive contrast test, or bubble test, to be safe if the patient has, or not, a communication. That's what I did with this patient. And finally, I have total security that the patient did not have interventricular communication. This patient reached a peak aortic flow velocity just over 4.5 meters, on average in both apical and 5 chambers cuts, and subcostal. Therefore, enters the classification of severe stenosis. Finally, I found the different indicators of systolic function and diastolic function preserved. And yes, I also know that there are 679 more that I could have referenced, but I wanted to share probably the most representative. And of course, being this a patient who showed aortic insufficiency, I evaluated aortic reflux, finding a pressure half-time greater than 540 milliseconds. Therefore, this defines a mild aortic insufficiency. Anatomic piece. Well, now, I bring you the surprise I promised you at the beginning of the video. Let's make an analysis, a description of the heart of this patient. Sadly, the patient we are analyzing, the owner decided to make him rest. Euthanasia, but she is very generous, allowed me to perform an autopsy, and I kept the formalized heart. So what we are going to do now is to describe the injuries that we have previously seen in echocardiography. The exercise we are going to do next, for me it is extremely important, because it allows us to close the learning circle. When we perform ultrasound, we have to do the mental exercise of carrying a structure, a 3-dimensional organ, to a 2-dimensional image. If this is the organ under analysis, and here I have a transducer, we know that the transducer emits sound waves, but it always does so on a certain plane. And that shot is the one I'm going to end up seeing in my ultrasound machine. Therefore, I must try to register as many plans as possible in different positions that allow me to draw a mental image of this structure in 3 dimensions. This is an exercise, especially for those of us who started doing ultrasound, quite difficult, and I would even say particularly difficult for echocardiography, because the heart is an organ that moves all the time. Then when I have the transducer emitting waves in a given plane, I have structures that are coming in and out of the plane all the time. Then I, by means of the different movements and dating techniques for echocardiography, I will try make as many plans and records as possible to do the mental construction of this 3-dimensional structure. Here we have the piece, and we are going to describe the most striking injuries. In this heart we can see the left ventricle, the right ventricle, the left ear, the right ear, and jumps into view the tremendous disproportion between the aorta arteries and pulmonary in a healthy heart. The proportion between these 2 arteries should be 1/1, i.e., they are arteries of similar size. of similar caliber. Instead here, we see a tremendous asymmetry between the two arteries. And for me the ratio is 5 or 6/1. And this consequence of the tremendous poststenotic dilation of the aorta artery, consequence of subaortic stenosis. If we get a little closer to the inside of the aorta artery, we can observe its valve. Its valve is tribal bar, but the valves are thickened and a bit asymmetrical. We will now explore the exit tracts, both of the right ventricle, as well as the left ventricle. Here I have already opened the right ventricle, and I'm going to introduce a scissors through the right ventricular tract outflow. The infundibular region and the tip of the scissors emerge through the pulmonary artery. At this point, I can see again the disproportion between the pulmonary artery and the ortho artery. I now have an opening of the left ventricle through an incision extending from the apex to the base in a line slightly oblique to the periconal groove. Immediately, we locate the left ventricular tract outflow, jumps into view. That injury we have been talking about for much of this video. A solid structure can be seen, complete circular, extending from the base of the septal valve, from the mitral valve towards the septum. And as we can see, it completes the ring, is a complete ring, and obstructs significantly, severely, the left ventricular outflow tract. With the heart in sagittal section, we can appreciate the injuries internally. In more detail, can be appreciated the left ventricular tract outflow, the aortic valve, whose leaflets are also affected, and annular injury, which corresponds precisely to subaortic stenosis, which obviously, because of the sagittal cut, is cut in half. By checking the other half of the heart, we can appreciate tremendous poststenotic dilation of the aorta artery. We can also check the aortic valve and, of course, the other half of the annular injury, which corresponds to subaortic stenosis, just below the aortic valve. When you feel the injury, it feels solid and rigid, and as we see, decreases significantly. The left ventricular outflow tract. Finally, did not want it to pass me by. I wish to show you the aneurysm injury that we have previously described. Interventricular septal aneurysm. We can appreciate this tissue that looked like a bag, which took the shape of a balloon, where blood flow was introduced. And I could register it with the Doppler function of my ultrasound machine. Conclusion. By way of conclusion, we will emphasize the fact that congenital heart disease are more frequent than we often think, and many of them, the patient does not show them until the problem is well advanced. Therefore, these patients, puppies at birth, have to be evaluated within the first 48 hours and, of course, within its health role. Deworming vaccines. Each time the patient comes for evaluation for a vaccine, it has to be revised in a comprehensive manner by the veterinarian. In this way, these problems can be encountered as early as possible. That's all, dear community. Remember to subscribe so that you continue to receive high-value content. I am Dr. This is Banda, Cardiologia Veterinaria, and see you next video.
Don't you want me like I want you, baby? Don't you need me like I need you now?